All right. So today we have Dr. Tia Powell. She was actually here at Columbia in the 90s, and then went to become the director of the Montefiore Einstein Center for Bioethics for 15 years. And she, during that time, held the Trachtenberg Chair in Bioethics. She's currently a clinical professor of epidemiology in the Division of Bioethics and Psychiatry. For 4 years, she served as the executive director of the New York State Task Force on Life and the Law, which functions as New York State's Bioethics Commission. She has worked with the National Academy of Medicine on many projects related to public health and ethics. She's a board-certified psychiatrist and fellow of the New York Academy of Medicine. And she has a book that came out in 2019, Reimagining Dementia. And that includes a history of Solomon Fuller, a Black physician psychiatrist from the early 20th century who contributed significantly to the original descriptions of Alzheimer's. But it's also a discussion of dementia, which should be reconsidered as not only about loss, but also about the preservation of dignity and hope. And I just on a personal level want to say, I didn't tell her this, for many years have been a big fan of Dr. Powell. Her program at Montefiore was, in many ways, a gold standard of mediation consultation bioethics. And people from around the country have learned from the program that she created at Montefiore. So it is a real pleasure and an honor to have her share a difficult case with us.
Two things. One, I'm losing my voice a little bit, so I hope the mic will allow me to get all the way there. We saw the air. If you can't hear me, if I start to speak too quietly, or just tell us say you're choking, or by whatever other signal you wish to communicate. It is a pleasure to be here. As I got off the subway today, I was a very young physician in training. I did my residency here, so for many years I was stomping around these very blocks long before this building was here. So I feel, but at the same time, renewed by this visit and also extremely old. So that is just a thing that happens as we get older. So I'm going to talk to you today, and I hope to engage you. I don't want to give a lecture if I can avoid that, partly because I'm just incredibly lazy, and I'd like to see how much work I can get you guys to do. For the younger people, that is really the secret for any successful career. So I offer that for free. So I'm going to start today talking about a case. I'm going to use initials. I'll tell you the person's name later, although some of you may know it, some of you may not. So JS, and I'm not using slides today. We're just talking. JS was a 52-year-old man who had severe developmental delays, and he had lived most of his life in an institution. His only relative was his mother, DS, Dorothy, who visited him most days. And he was sort of going along okay. He was described as having a mental age of about 18 months. We'll come back to that later. He had a couple of words, couldn't communicate, but primarily with just gestures and showing you without words how he was happy or in pain, whatever. And he was sort of bouncing along in his life there at this institution in New York State until one July morning, the clinical staff there found that he had some blood in his urine. Oh, what? Okay. So they work him up, and actually he has bladder cancer. They ask his mother. She's absolutely eager for curative treatment to go forward. What do you have? Turns out he needs radiation, and they don't do that at the facility where he is living, where the people with severe developmental delays. So the only facility that will take him requires her to become his guardian. In the last 52 years, she never needed that piece of paper, and it takes several weeks. So it takes till July for his loving mother to become also his guardian. Here we can pause to say, really? Was that necessary? No one else was fighting for the spot, but in any case, she went ahead and did that, and he gets radiation therapy in, I think, August. Okay, so far so good. The clock ticks on, go from August to September, October, November, December, January, February. He's in remission. That's a great thing. And then he's not. So they see blood again. So, this goes on. They don't know quite what to do. They get more of a workup. it's metastasized. It's certainly in his lungs. It's probably a lot more other places, but he's relatively difficult to obtain the cooperation to work further. Everybody agrees this is metastatic. They don't have a curative option. So this is where we are. This is the illness that he will likely die of. And he doesn't have that long. It's not this week, but, probably would meet criteria, I would say, for hospice, but let's see, maybe not. Or at least the criteria expected to die within 6 months. The way hospice criteria are changing is a whole other topic for discussion, actually. So they have to transfusion. He's losing a lot of blood in his hair, loses blood when he pees. Also, he's got advanced cancers, probably not making much blood. And his hematocrit is going down. He's severely anemic. And so they say, we're going to transfuse him. This is a man who's pre-verbal, who has a very limited understanding. He is, no question, he has absolutely no capacity to engage in medical decision-making, to know what cancer is, to know what the treatment of cancer is. So they want to transfuse it. And his need, as happens in such a case, increases. And now he needs 2 units every 8 to 15 days, and he doesn't like it. And when they give him transfusions, it actually makes big clots come out in his urine, and that's really scary and also painful. So he won't come anymore to the ROM for the transfusions. So they have to really kind of drag him in, and then they start sedating him an hour ahead, and then that's not enough. So they restrain him physically as well. And his mother goes, hello, you told me he needed treatment. We got him treatment. That got him time. That was good. I don't oppose treatment. But you told me you can't fix him. How is this helping? So let's pause there for you guys. Happily, we have this ethics committee here. What do you want to know? What do you want to do? What's happening? Let's think together. We're the ethics committee. This is what they've called in. This mom is refusing transfusions, and the clinicians have requested a consult. So what can I tell you? And there'll be some things I may not ask you. So I'll be a slightly unreliable narrator. But okay, so who wants to jump in? Who's our ethics committee? What are the resources you have? What options? What's going on? In the absence of volunteers, I will choose conscripts. All right. Yes, thank you.
So I guess I'd want to maybe understand what would be the expected outcome by stopping damage conversion. What would that happen? Like, it's happening. What did you think like outcome?
Yeah. Okay. So what would happen if you didn't get that treatment of transfusions? Okay. It's unclear that there's going to be. He's probably has an expected lifespan of maybe 3 months with or without treatment, with or without the transfusions. So he's not imminently dying, but he's not going to recover from this. This is a terminal cancer. Those are all words that are difficult to interpret, but those are the words that we use. So that's an excellent question. What would happen if we stopped? Might make a difference. I will say that there may be some disagreement that some of the clinicians feel that he would die sooner without the transfusions. So I'll try and be fair and say that. Okay.
Yeah.
Are there any other effects on this man by getting the transfusion aside from not being able to help his cancer? Is it negatively impacting you in other ways? Is it positively impacting himself in other ways? Like elements that the transfusion are getting.
All right. So we're talking about risks and benefits. Can we get some more detail here? He seems to be more withdrawn. He used to be quite jolly, kind of bopping around his unit and always very cheerful with everybody. No longer true. He's a little frightened, he's kind of withdrawn. He's also very ill, so maybe he's just losing energy. But it looks like it's frightening to him, the actual act of it. It cannot cure him, surely. It doesn't really seem to give him more energy or anything that you could find. And the mother's view is that this is only negative. You're scaring him, you're frightening him. It hurts physically. He doesn't like being restrained. That never happened to him before. So her view is, I don't see the benefit. The clinicians say he's losing blood. This is not good. This is a treatment we have. We think we should do it. So this is part of the issue. that the risks and benefits are defined differently by different stakeholders, which is a common factor in almost every ethics consult you will ever see. So that's part of the ethics judgments that you make, whose data count, whose view of this gets incorporated. So we're already getting into slippery ethics territory here. Yeah.
Has the mother found out yet whether she has the power to make the decision at her step? Obvious. So
And that's where we're pausing. She's saying, do this. They're saying we're uncomfortable with it. So we're pausing there, and then I'll come to you in a minute and say what their first step was.
this is another question. You said his mental capacity that of an 18. So I just wonder, pediatrics, the parent would be making the decision. Do they ever look at mental capacity when it comes to making a decision on?
You know, it's certainly parents generally give consent for minor children. She now is also his legal guardian. She has been his parent all the way through, and he has not cognitively progressed as other children do so that he can take over the mantle of responsibility. So that is part of the question. Should she still have that capacity? But, you know, parents don't get to refuse everything. There are some things that they can't say no to. So that's part of what the question that these particular clinicians are raising. But you're onto something there. It seems odd that she doesn't have that authority, or so it does to me. The other thing I'll say about 18 months old is that how many of you have reason to be around 18-month-olds these days? Yeah. I mean, what are some key features about that? What is a thing you notice about an 18?
What would you envision? What?
Healthy, be very active, super active, curious.
Yeah. They are learning machines. You can't keep, when one of my children, now quite adult, was about that age, we learned that she could climb out of her crib because one Sunday morning, while my husband and I were sort of semi-asleep in bed, she arrived in our room with a banana and a large knife, like a carving knife. And so working back, the problem with that, she had climbed out of her crib, feeling a little peckish. She went to the kitchen. The bananas were up on the counter. She drove a chair over, climbed onto the counter, got a giant knife out of the knife rack, somehow got a banana off a stack, climbed down backwards with a banana in one hand and a giant knife in the other, onto the chair, and then back down onto the floor, and came waddling down the hall to our room to see if we could open the banana. That's an 18-month-old. They are wildly learning every minute, and you can't keep up with them. So it's kind of tragic to call this man an 18-month-old because he is frozen in a state where it's very difficult for him to accomplish things. That love of accomplishment is already so visible in a healthy 18-month-old. When they can do something that they couldn't do earlier that day, they are over the moon. So it's the way we use language can get us into trouble. And I think that it does in this situation. I think it did in this particular situation. Yeah.
Mom, at first, wasn't she prepared to treat him so her whole works? At this point, the pause, she held all her goals for today.
I think so. I can ask her that directly, but I think they did change, and that they ought to have changed. It's because now she's being told, we did what curative treatment we had. We offered that to him. This is not a case of, well, he's disabled. We don't want to give him treatment. No, they did that. They gave him what they had, and actually it gave him 6 months, 7 months of good remission. That was great. And now she's being told, but we can't do that again. That doesn't work. And we don't have more curative options. So I would say that it would be right and proper to say, okay, so what are our goals be then? What are the goals of care? So you're coming up on an incredibly important issue.
Like, what services are involved? Adults, or is it just oncology? Right.
That is an interesting question, and I don't have a full answer. This is a facility that cares for chronically disabled people. I'm sure no one is in-house. They don't have an oncologist working there every day. So they have consultants coming back and forth, but I'm not quite sure actually how that was working. So is it the same person over and over? Is it that they go to a local hospital, a particular one, to offer this kind of care? So I'm not sure, but it's an important question. Okay, other questions and comments?
Just a quick question. What's her culture, or what is mom like, or what's the family like, and what is other relationships are, or is there anything else that sort of helps us understand this dynamic better?
Yeah, I don't know much about it. They're white. They are middle working class, I think, German background family. And they live in a somewhat more rural part of New York. They're in New York State, but not in New York City. They're in a little bit more of a quiet, smaller town. Yeah. All right, so you want to know what happened? So you're the ethics consultant. What do you do? How would you begin to say, well, this is a thorny problem? Where would you go? Who would you talk to? What would be your first steps? What do you want to do first? A few of you already made suggestions about that. Who do you talk to? You do an ethics consult. Where do you start?
It's difficult because to me it seems really obvious that the mother shouldn't be able to decide. So I don't even know how to start that.
So maybe you would talk with her. But yeah, you bring up a really interesting question. It's quite challenging when you're in the ethics consultant. When you're the ethics consultant and you read this thing and go, am I missing something? Because this doesn't sound like an ethics dilemma. This sounds like you're just wrong, sir. I mean, like, I can't, so you're unhelpful if that's what you're going to project to your colleagues, or to the family, And maybe that you agree with the professionals here saying, well, I don't want to tell you, you got offensive. But so there's such a strong presumption that you have that the mother should be decided. You can lead with that. You can do what I refer to as playing Columbo. So you can go to your clinical colleagues and say, forgive me, I'm really confused here. Wouldn't it be the mom to make the decision for this patient? Help me out. So you can kind of do that. So maybe we would come to her. And frankly, that is where I would start. I would also, who else would you want to interact with? Yeah.
I have a question. Is she paying for the treatments? Is she paying for the transfusions?
I don't know if he is completely awarded the state. He may be. And I will confess now that this is some time ago. So it may be a little bit different now. But why would that make a difference to you?
I feel like that gives more agency when you're able to, the financials are in your hands. It's them.
Are they though? I mean, even if you have insurance, I'm not sure you get to control. It's a really interesting question.
I actually would think of the opposite. If she has financial incentive to not pay for his life anymore. I mean, I don't get my making it and stay.
Yeah.
Maybe, yeah. I mean, that's an end of life, dying question. You don't get or have enough resources.
I think it's such an interesting question because we imagine this family this patient to be receiving Medicaid. In some ways, the family has less agency. Okay? She's not paying for the treatment, but it's being made according to various other institutional and, hard to pin down guidelines. So she might, you'd think if it were about some other kind of decision, being the one who pays might make all the difference, but it's actually the insurance company that pays, typically in medicine, and that's not something you control. In my experience. Yeah.
Well, what's that called, the consult?
I'm just calling it consult. Yeah, this is a thought experiment.
Are the providers working with
Well, they're upset that she's saying, no, I don't want to do it. That's a big problem for them. So, all right. So I've been creating a fiction. This is a case from some time ago. What they did was they took her to court. So this is a while ago. This is 1980. There is no ethics consult. There is no Family Health Care Decisions Act. There is no healthcare proxy form. There isn't even a DNR order. There's a lot of stuff that is your bread and butter in terms of trying to, offer ethical treatment for your patients that comes up because of cases like this. But this is the case that actually brought me into bioethics in the past century. That's kind of a kick in the teeth, but in a way, it's true. So I read about this as a medical student and had the experience that you had. It's like, wait, what? It's the mob. What are they doing? What the heck is going on here? What is happening? So they took her to court. So guesses, what do you think happened? How did things unfold? New York State, good blue state. They didn't have that particular metaphor back then at all. And so something really interesting happens. You what else more? How can I torment you? Okay. The lower court actually sides with the mob. They say, really a person without capacity can't make their own decisions. That's tricky. But they can have somebody else who's well situated step in, and it looks to us like that person is right there volunteering for this duty. And she has the piece of paper, and she's also got DNA. She is this person's person. She is his person. She's been there day in, day out, looking into him. And by the way, in the period when this man was little, it was strong advice that such a child be institutionalized. And he'll do better. That's the kind thing to do. You can come and visit, but you should not try to raise them at all. I don't know the specifics of what he was like as a little child, but if you're thinking, why did she have him institutionalized? I would say that was the sort of really overwhelming and standard advice back then. So the lower court says, we think the mom should have that agency that, there's not so much to be done for this man, but we're going to let him keep having transfusions while this is appealed. So the hearing isn't for another 3 months. And then it goes up to the higher court, and they do their findings. They have all kinds of other things. And they decide by the time it gets to New York's highest court, Judge Saul Walker, who was the head of the highest court in New York State at that time, opined that absolutely you had to have transfusions. Why would you argue that? Why did he? Something. Yep.
The state doesn't get to decide who dies. I mean, they do. I mean, maybe there is an argument around it. You can make the other argument for sure.
Yeah, we need to look at both sides. Like, he came up with a different side, and he was our head judge. So, what they said is something that I'll describe as I will come back to that. They said that yes, okay, fine, he's dying of cancer. He's also bleeding to death. And the court cannot allow someone, even someone as close as a parent or sibling, to let somebody bleed to death when we can prevent it. We have to prevent him bleeding. What are your thoughts about that? This was the determining law in New York State for decades. Take it apart, hold it back together, or are you in favor of it? What do you think about that? He's about yeah.
I'm looking at it. I find it hard to something that I agree. Even though that like the person who it's all happening to, it doesn't happen as fast to make that decision. His guardian should be able to invite credit still. And I understand like the differentiation between letting you pass from the terminal cancer as opposed to bleed to death. But if that's a mental struggle, an emotional struggle, that's only going up the law phase. Yeah. It doesn't seem, and that's not what they want. It just doesn't seem like it's the state's place to make that decision.
So this is an overreach. That is what the lower court also thought. I don't think we should be, we the judges, I don't think we should be in this business. Families have been working this out with great pain and difficulty, but we're working it out without our assistance all these many years. And I don't think you want to set a precedent where they have to come to us for permission to stop treating someone with a terminal diagnosis. That doesn't sound like a good. And indeed it was not. Yeah.
I don't know if it's too far, like, past what you're looking for a descendant, but given especially the time in which this was occurring, is there any thought about whether they're going to have some bias at play here about who is qualified to make critical decisions, thinking about female mom, not trained in medicine versus like presumably mostly male doctors at that time. Like I almost wonder if the thing then reverse. Mom had one egg and the doctor wanted something else, but they still decide with the doctors in who they are that they're treating.
Yeah, it's a good question, and I can't know. I would assume that this is also a gender discussion, that this nice old widowed mom is not going to win an argument against the professionals who are in their home court in the institution, and they're telling her, we know all this stuff, and this is what we must do. And I think she's not a professional. I don't think she's a wealthy woman. I don't know her level of education, but I think not just gender, but in every way, the field is not level here. And it's also, yeah.
Was the decision by the chief justice a unanimous one? Was there a second?
There was a dissenting person. Thank you. I love this guy. He says a lot of things that are really interesting. All right. So the find it quote from the. All right. So it comes up. It gets reviewed. It goes to the Superior Court. It's file. The dissenting judge, Judge Jones, says courts are poorly situated to make these decisions. We move too slow. It's an adversarial system. That doesn't seem appropriate. Shouldn't we be all working together here? I don't see the you win, you lose thing as a helpful model for these decisions. Doctors and families have been making these decisions for years. Please do not require judicial approval. There's no evidence that transfusions are extending life. We don't see any reason to think that there's actually that benefit to care. And what other benefit there would be is not obvious. So tell me why we need to do it, is what he insisted on. He also said the term at that point was extraordinary treatment. There was ordinary and extraordinary. Ordinary was like keeping someone clean, keeping them warm, doing the various basic kind of obligations just to treat a body with respect that's in your care. Extraordinary would be something that you could say no to. That was sort of an early formulation of thinking about why some treatments are different. If it's super risky, if it's super painful, if you've had 8 rounds of chemo and they propose a 9th and you go, I'm very well informed about this chemo. You're telling me my chances are very small and I'm going to say no, thank you to that. People would say that's extraordinary treatment. We wouldn't push that. We wouldn't, this is a very well thought out choice, well-informed person. We don't have much that we've got to offer here. And if pain is a big issue, then fine, stop it. So he said, I think this is extraordinary treatment for this man in this circumstance. So, and I think that's important to remember because we can't pass judgment on people who were a long, long time ago. There was no palliative care then. It's not like you could call the palliative care fellow. There was no palliative care fellowship, as far as I know, in the United States at that time. We hadn't really thought about the goals of care discussion. That is a completely obvious thing for this context, hadn't been formulated. Those words in a phrase did not exist at this time. So people hadn't really come to that because medicine didn't have as many interventions. I don't know all these things people were doing. We also had a very different notion about the relative power of patients, families, and professionals. It's only in the 70s that we begin to have informed consent law in the United States. where you begin to be really required. And with a few early cases before that, but that's de minimis. I'm taking your surgery would have done a job, not really anything about the details of that, not a real discussion. So it's early on in terms of stuff. So bioethics is still new, it's still a new field, but we have also come some distance because I don't think we run this case like this today. So the other argument that Judge Wachtler made said, of course you have to give up blood. Blood is like food. It's not a treatment. It's just a thing that everybody needs. You have to have. So this is my ironic coda. It's 1981. Anybody want to comment on blood transfusions? No. What happens? Yeah, this is, there was a whispered HIV. This case is decided in January by the Supreme Court after various appeals. Alas, the patient was not able to attend because he had died several months earlier, getting transfusions to the very last. Some weeks, I think it's January, that the decision is. In March is the first report in the Morbidity and Mortality Weekly Reader saying, there's a crazy batch of cases, these young men with this weird pneumonia that they shouldn't be getting, and equivalence is crazy. So that's it. That's what is part of our knowledge that we now have, that transfusion is not an everyday, everybody gets it, it's just fine. It's like a Band-Aid. Everything has risks. We are so much more cautious in assuming that everything we do is always beneficial. We hadn't had that education. A lot of people got transfusions willy-nilly. Let's just give it to them before surgery. Being able to lose blood, it would be great. We did think of transfusions like a thing that can only be good for you as recently as the 1980s. So, they knew some things about our age, but not a lot. So we have changed now. I don't think, I'm not a hematologist. I can't personally, though, put any credence in a decision today to treat somebody who has terminal cancer and who is declining transfusion, even without capacity. He still very capably feels pain and is inconvenienced by this. It's inconceivable to me that somebody wouldn't order regular transfusions for such a patient. How would that be a thing? I don't see it. Even though I think maybe he would die a little bit soon, but if the family's saying no and the patient is acting no to his capacity, I don't think it would happen. Blood is scarce. Blood has risks. We are a great deal more cautious about our use of it. So that was sort of the ironic coda. The other ironic coda is the cases in bioethics that come up in the decade or so following this are also about food, about the right to receive food. We don't now think of things in the same way. We let people, in a variety of circumstances, remains controversial, but we let people say no to food. They're Bouvier, Cruzan, all of these, Scheibel, very controversial. But even about food, our notions have changed. It's something that I've written about is using feeding tubes for end-stage dementia. Right? So the American Board of Internal Medicine and various other groups have signed on to don't do that. People lose the capacity to swallow. Yes, that's true. It does not increase quantity of life to offer a feeding tube in end-stage dementia. And it absolutely decreases quality of life because in many cases that person will need to be restrained because of the tube is in the way and stuff like that. So our notions about how we can be kind to people when constitutes taking good care of somebody are radically shifting. This isn't that long ago. It's in my lifetime, but it's almost the entire lifespan of bioethics in its modern formulation. Obviously, if you want to go back to the Hippocratic Oath, there were thoughts about doing the right thing, but our modern notions of, being a little more humble, having a little bit more humility about whether my idea of what benefits you is the only game in town, or whether or not this patient, even a patient with very limited cognition, actually I think was quite eloquent Right? I mean, he didn't have the brain that could take him through education, but he made his missions known. Nobody disagreed with that. They actually knew what he wanted. Now, listen, for a healthy toddler who needs some treatment, they may absolutely make their wishes known. And people may also agree, yeah, but we're going to do it anyway. I mean, this child has been hit by a car and he doesn't want to go to surgery, and off he goes. So we can make that judgment on behalf of someone whose judgment is not refined enough to think about, big ticket pros and cons. But I think, have shifted a lot. So I'm gonna leave it there. There's a lot more we could think about together. Other questions, problems? Yeah.
It's an interesting sidelight in this case, for those of us old enough to remember, Cofounder resigned in disgrace because there was harassing ex-girlfriend. He came know that he was the one who were following over, came out and he resigned. He had to resign.
He did resign. Yeah, I think it was an early cancellation in some ways after Trump. He wrote an article in a bioethics journal about his work and about this. I actually think, I don't even know if it's an ethical thing to say. It struck me as an article written by somebody who was cognitively impaired. So I think his judgment and his thinking was probably not the same as he was when he got older, as it might have been in the beginning, which is a whole nother ethics problem in medicine as in law. We don't do regular evaluations of cognition. And I don't want to be ageist. I certainly don't. Since that would be aimed at me. But we know a lot of people actually have a declining cognition, a substantial percent by age 80. And we have people sitting on the federal bench. We have people providing medical care, providing surgery, doing all kinds of stuff. We don't evaluate because that would be ageist. But I also feel like, yeah, but our patients, is that okay? So that it does create a lot of other issues. And I think this was, I don't argue that the problem in Walker's reasoning was because of his cognition. I think he argued using analyses that were acceptable in that day. The notion that food was for everybody, absolutely common. The notion that transfusions were only a good, absolutely standard. So I don't think this decision is affected by that, but I do think possibly it's later disgrace and who knows what was going on with him. Yeah.
Oh, I just had a question about, I guess one of the choices the woman could have had would be to choose another provider who may have a different approach to food. So,
that's a really interesting question. That's what you would do, right? I'm really uncomfortable with the care in this institution. Let me take you somewhere else.
yes, it's medical advice, but maybe not against medical advice from somewhere else.
So then and now, it's not easy to get a place for a 52-year-old with severe cognitive delay and dying of cancer. So I don't know, even today, how easy it would be for her to transfer him. Maybe he was in the acute care hospital at this time because he's so sick, but they probably just have him on a little kind of clinical ward at the institution. So her hands may have been more top. I don't know the answer to that, but I suspect we didn't have huge numbers of beds for such a person then, and that has not gotten better today. So she may not have had such an easy time. I don't know. I don't think he was the ward of the state because then she couldn't have become the guardian. But that is certainly true of some people who had that level of disability and certain background. So they may have had some legal power. But yeah, today I think you would say, take in court. I'm the mom. I'm going in here. You would do in here, I think, today saying that. And you would get a string of palliative care physicians to say, what are you doing? This is crazy talk. And you'd had a lot of precedents that have been changed because of cases like this, where people said, I don't think we've got it right. I don't think we nailed this one. This doesn't seem like the best use of medicine or frankly the law. I don't think with our combined wisdom, all of these big New York institutions, that we've done all that good a job by John Storer, which was the name of this. Barbra, yeah.
Yeah, no, it's such a great case and there's so much. I was thinking the big question of vulnerability and protecting vulnerable patients, which I do think was in some ways at that moment what New York State thought they were doing. Right?
Absolutely. Yep.
They want, and it does still leave us with the question, how do you provide the balance of protecting vulnerable patients when the person who is making the decisions, maybe this gentleman has not been a person who's ever been able to express a preference, right? And also would the case be different if he had been someone who suffered a traumatic brain injury at the age of 28, someone who had been able to at one point express a preference and now can't. But I guess in general, like what's your vision of how we protect vulnerable patients? And we were talking about even before the Family Healthcare Decisions Act, like I think that the difficulty we had in helping people end their life reasonably was actually because of the overprotection, right? They didn't want, I think the government doesn't want us putting people to death too quickly who can't speak for themselves.
So this is, this is a big swinging pendulum through history. There is a long and horrifying history of not providing treatment or in fact actively killing disabled people, right? So that looms over all of this, and certainly for the state. There were, I remember a very controversial paper that I think appeared maybe in the New England Journal proposing it was perfectly reasonable for children with Down syndrome who also had, I guess, esophageal atresia to not get operated on because their life is just going to be terrible. This is quick and easy. Don't get into it. No, don't do surgery. And people went like their heads exploded. So you could get that published in the New England Journal, in the 20th century. So there is a long history of saying, you don't count. Your life is not worth our trouble. So we don't want that. And I think that is exactly what made the state say, oh, not so fast. But, and there definitely were disability advocates saying, yay, they made him get treatment. But that was sort of then. I don't think now they would say, yeah, but not maybe this treatment. Because it came to be that you couldn't die there without, having been able to give clear and convincing evidence of what your wishes were. They couldn't get you a DNR. Certainly, I mean, as I say, there's no palliative care, but it was really difficult. In my one of my prior incarnations, I ran the state bioethics committee, and the Family Healthcare Decisions Act took more than 20 years to get passed. And all it basically says is that if you have somebody to make decisions for you, that's really important, that you can appoint a proxy. It was enormously controversial. People didn't want it for this reason. Oh, that sounds terrible. We totally should ban proxies. It's hard enough to really get your mind around, like, what, why? But I think there was this notion that this would be euthanasia, this would be putting vulnerable people to death. So then, now it's tricky. We don't want that. But it's also true that there can be kind of a fine line between protection and control. And you can, in fact, be so protective that you eliminate the rights of vulnerable people. There are no options for you. There can be no DNR order, which was essentially New York state law for a while. And if that's somebody in your family who's suffering, you see and appreciate, you're not going to love that. That's not going to feel right to you. I would in many cases. So I do think this pendulum swings back and forth if we think about what is the hard here, and how do we balance out autonomy? Who gets to make their own decisions? Probably, there are a lot of decisions you wouldn't let someone make who is profoundly disabled, but they're kind of the final arbiter on pain. So for ethics consultation, one of the things I was digging for earlier is you would talk to this mother. I would also see John Storer. What's he looking like? I know he can't have a sort of detailed discussion with me about his options for cancer treatment, but he's still a person. I think our inclination in as being professionals, even today, he might very well be left out of a lot of meetings and conversations. But actually, I think to do an ethics consultation, if there's a person you're talking about, you should at least have seen them. You should know what they look like. And even if they say this is, it's just somebody who's completely comatose, they're in PBS, there's nothing happening there. I have been told that about a person who I saw writhing. So that's a different set of circumstances. If this is somebody who can't suffer, someone who's brain dead, really, that changes where the moral weight goes. If this is someone we can't hurt them anymore, that's different than we're hurting them right now, actually, and they can't stop us from doing that. So, yeah.
So we have a question from our colleague David Hoffman, who's attending remotely. He asks, is this another example of your admonition that we typically only question people's decisional capacity, in this case, the mother's capacity to make a best interest decision when they disagree with the recommended treatment plan?
So maybe David has teased me in the past by saying that is the Powell rule. That we don't question anybody's capacity until they say no. So maybe I think that was a much more hierarchical time in medicine. This is the 1980s. There's much less diversity in any medical school class by class, by gender, by race, by anything. So there is a sort of group that has the power, I get to say how it's going to be, in a group that's everybody else that doesn't get to comment too much. So I do think it's true. I also think it's okay to question somebody's capacity when they're saying no to something that you really think might hurt them. So, if you have a patient today who says, I don't want that vaccine, I've been reading about them and they're going to make you sterile and they're going to do this, you don't say, got it, you are absolutely with it. Please don't give your child a measles vaccine. I don't really see a lot of people you're saying, your autonomy, I get it, we're not even going to chat about that. So it is, that's not a capacity issue, but an information issue. But the health professionals in a really tricky spot when you say, I think it's important that you do this. And the person says, no, because you are going to feel bad if they get hurt and you think they will. So I don't have an answer for you that, but I do think it remains a really pressing issue. When do you have the right information? Can I show you some data, or is it not about data? Is it you don't trust me? I get that. What can I do to help with that? We've got a lot of work to do, and we have a lot of no saying these days. So we need to up our game because we're losing, actually, at the game of people saying no. Yeah.
It's interesting to see if the conversation is different, how the outcome is. What if the mother respects and everything up?
Yeah.
And with the positions when flowers officers who feel is harmful to the patient,
Right.
would there still be a court, stop her from having our treatments done? That would be difficult.
Certainly, the question was, what would have happened if the mother had been saying, go, 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 and the physicians were going, go where? We've done the things we can do. So, I don't know. It's also a thought experiment. I think we need to figure out how better to communicate with people. So if there were any single take home with this, I would say the single thing I would hope that you would most not do today is first go to court. Please don't do that. Talk to these people, figure out what's going on, talk to your clinicians. We are also human, and we are all aware that we have colleagues who are probably pushing a little bit farther than we would for somebody who's terrifically ill and probably will not recover. And we are also human, so we don't get everything right. We need to figure out, are there goals that we can all agree on here? Keeping him comfortable, is there a way we could comfortably transfuse him? Maybe not, but is there more we could do on that score? And just doing normal human interaction and support, and talking to this mother about how terrible it is that she will outlive her son. What's that like? Wow. Yes.
Sorry, Oswald, but what should the executional response be in the case of cases like Henrietta Lacks, where there's obviously in a great amount of scientific discovery and so on, but consent was never taken because what it can be.
Henrietta Lacks is such a complicated case. I don't think that we can really know whether the standard at that time was followed. The standard we would like to see today was certainly not followed. Case Henrietta Lacks, who, as we know, became the source for the cells for the human. Do we own reparations? Is that really what you're asking? That's a really good question. I think the original people who did the work were not the ones who made the profit. But there are still people who did make profit. I think personally, and this is why I'll never be in charge of Hotline, is that it's so much cheaper to be a decent human being, to ask a family, what would you like? Could we set up a scholarship? Would you like to have a place at Hopkins for someone in your family or someone that you would select? Would you like us to do a course on giving consent or what's owed to human subjects research? You could do so much with that. And in fact, that sort of mediated way that focuses on apology there's a lot of data to say that it really works better than the constant stonewalling that is our current usual legal response when there is medical error. So I'll never be in charge because I would say, totally, find that family, talk to them. Maybe it's money, but maybe it's like an education thing. You'd all be better off for it. So anyway, that's why I'm not going to get that job. That's what I would do. And I think it would bind that community to that institution in a way that would be quite healing. And I actually don't know what they're doing at Hopkins. They may have done all of that and they certainly have the funds, I would say, to do a good deal with the community of Baltimore.
One last question from me, Quinlan, did it not have an effect on this case when it went to the court? I would have thought this idea that, Karen and Quinlan, the parents argue she's suffering while she's on the or we believe she's suffering, and we don't believe she has to undergo suffering to extend, even in this case, it was to extend her life.
Right.
And so I'm curious why that didn't put itself into this space.
Yeah. It's so interesting, sort of what things influence our thinking. So Quinlan was decided 72, 73. So that thumbnail sketch, this is a young woman who we don't really know what was going on. She had some eating disorder issue, something, and she ends up on a ventilator, unresponsive. She's from a Catholic family. She has devoted parents who say, this doesn't seem like living to us. We really like you to take off the ventilator. And the doctor said, that would be killing of you, or that's silly. That's, crazy talk. We're not taking off the ventilator. They fight for years. The parents win, they take off the ventilator and she breathes on for another 8 or 9 years. So it's like when we use the adversarial system, we actually kind of lose a lot of our options. If you had said, what you would do now is say, you don't want her on the vent. She's in PVS. A lot of people like that. They breathe on their own. PVS by itself doesn't require that. They didn't know that then. There weren't enough people with that. So that's a ventilator case. It's before bioethics. These are guys in an institution for the chronically disabled. I don't even know if they knew about that. Maybe they did, but we're talking about transfusion. There was no overarching. We're talking about end-of-life care. We're talking about palliation. We're talking about patient rights and their surrogates' rights. None of that conversation have really come to the fore. And Karen and Quinlan outlives this guy. Her case, as far as I know, though her case was decided a decade earlier. Yeah.
What did you comment about that? There was a thought that if clinicians stop therapy, that you would sue institutions or sue and astounding use their ability to work at a hospital.
Yeah. So there is absolutely then and now a fear of being sued, and also for being, there's that. There's also, I think, the fear of being responsible. I'm killing this person. I can't do that. I'm a health professional. I'm supposed to support life. So I think that is a fundamental cognitive problem we have around end-of-life care. Still now today, for the book I'm working on now, I'm interviewing a lot of people who have had to make decisions for someone else who can't make decisions. I interviewed a woman who was brilliant, who is a professor, who knows a lot of things, and she had to make a decision for her husband, who had been dean of an Ivy League, something or other, who has severe dementia. And they said, we'll take him to the OR. He's really sick now. We think he should, sign off for this part. So we really want you to sign a DNR along with this. We take him for treatment now, but we don't know what's going on. She just groaned and felt for the whole night. She didn't sleep while she waited to understand about the outcome of surgery, that she had agreed to his death. She could not convince herself. This is the most educated and intelligent and thoughtful, wise person that you'll ever see. But because it was someone she loved, she wasn't functioning in that setting the way she functions when she's being a professional self. We don't want to feel like we hurt somebody, like we killed somebody, especially if it's your family member, but for professionals too. We have to think about that better. And I think it's arguably partly our confusion that makes it so hard to communicate with patients and families who sign the DNR order. It's not agreeing that he should die, in saying he is dead. We shouldn't attempt to do something else. That's not on you. That's not on you. But I think our ambivalence kind of trickles through, and it's part of why it's so hard for people to make those decisions. And that's my theory. It's totally evidence-free, but that nonetheless, I do think it is an important aspect of why these decisions, though we've gotten better, we've been better, we're much better able to discuss it, and we'll know we're time past time. So I'll shut up in one more minute. I think we've gotten better. We do talk. We at least know that we could be better at talking to people about this. We know that we could do more in honor information we offer to patients, families, to give better options at end of life, better palliative care. We know we could do better. We do a lot better than we used to, but certainly have a fair way to go. So I will leave it to thank you very much for your patience.